Verrucous carcinoma is a diffuse papillary, non-metastasizing, well-differentiated malignant neoplasm of the oral epithelium. Coming to the etiology of verrucous carcinoma is usually due to tobacco chewing, snuff dipping, and this is usually seen in 50 to 80-year-old males. The common sites are buccal mucosa, gingiva or the alveolar mucosa, the hard palate, and the floor of the mouth. Coming to the clinical features, it is a slow enlarging, large, broad-based exophytic neoplasm with a white to tan, heavy keratotic, warty surface. The surface is usually raised, pebbly or warty with multiple rugae and deep clefts in between. The fully developed is usually exophytic, grayish red, bulky lesion with a rough, shaggy, fungating surface. Keratotic horns are usually present, which is excessive accumulation of compact keratin that can lead to the development of hard, elevated projections onto the surface of the lesion. Some of them can be invasive, some can cause very extensive pain, tenderness, and difficulty to eat. The gingiva is usually fixed to the underlying periosteum. Coming to the histology, they are highly differentiated malignant epithelial cells which proliferate as broad papillary structures. They're low-grade malignancies, and these cells lack the cytogenic criteria for malignancy. The hyperplastic epithelium usually is covered by a thick layer of parakeratin. The continuity of the surface is usually maintained by some filiform processes, which usually resembles the church spines. There is massive enlargement of retinages, which look like elephant foot, which are invading into the underlying connective tissue. Parakeratin plugging is usually seen, which are deep cleft-like spaces lined by a thick layer of parakeratin, which extends from the surface of the epithelium and projects into the center of the bulbous retinages. We have the intact basement membrane, and the underlying connective tissue shows intense inflammatory reactions. In long-standing cases, usually there is compression of the underlying superficial muscle bandoles and there is saucerization of the cortical bones. If left untreated for years, they can turn into squamous cell carcinoma. Coming to the differential diagnosis, we have papillary hyperplasia, varicose leukoplakia, squamous cell carcinoma, and chronic hyperplastic candidiasis, and also pseudoepitheliomatous hyperplasia. Treatment is surgical excision and laser therapy. In this diagram, we can see that we have cleft-like spaces filled with parakeratin, epithelium showing minimal dysplastic features. We have broad elephant foot retinages and connective tissue with dense inflammatory reaction. Again, broad retinages and the parakeratin plugging. Here it's more clear where it is reaching the center of your retinages.